Professor Cassidy, Professor Bax, distinguished panelists, members of the European Society of Cardiology. It's a tremendous honor for me to be in front of you today on behalf of the Executive Committee, the Steering Committee, and my two co-senior authors, Dr. Peter Libby and Dr. Robert Glynn, to have the honor of presenting to you the primary results of the canakinumab anti-inflammatory thrombosis outcome study, or Cantos. In 1994, at the heart meetings, 23 years ago, all of us heard the results of the 4S trial. That trial changed the way we think about the prevention of heart disease because we moved beyond diet, exercise, and smoking cessation to recognize the tremendous power that would be associated with LDL reduction and lipid lowering. And since that time, we have focused almost exclusively on ever better ways to lower LDL cholesterol and the tremendous success that approach entails. But over the same 25 years, there's been a group of researchers very interested in fundamental vascular biology as well as in translational biology, addressing concepts that have to do with inflammation and its role in atherosclerosis. These are our data published exactly 20 years ago, describing for the first time that if you measured inflammation with the high sensitivity CRP assay, you could predict future rates of cardiovascular disease independent of LDL cholesterol. And this was done in the context of an aspirin trial, an antiplatelet drug with anti-inflammatory properties. Over the past 20 years, we've learned from a clinical perspective that plasma levels of inflammatory biomarkers, including high-sensitivity CRP, but also interleukin-6, robustly predict first and recurrent cardiovascular events independent of lipid levels. We also learned in 1998 that statins are both lipid-lowering and anti-inflammatory, and that the greatest benefits of statins therapy accrue to those who not only lower LDL cholesterol, but who also lower the inflammatory burden. In primary prevention, in 2008, we published results of the Jupiter trial demonstrating that individuals who had low levels of LDL cholesterol but elevated levels of CRP benefited markedly from statin therapy, and those data changed guidelines for prevention. In secondary prevention, however, clinicians have now begun to distinguish between those with residual cholesterol risk and those with residual inflammatory risk. So imagine we have two individuals, both with prior myocardial infarction and systemic atherosclerosis, both of whom have a pro-inflammatory hyperlipidemic state, all of whom international guidelines would put on statin therapy, preferably high-intensity statins. However, on the left-hand side, approximately half of those patients will have an LDL cholesterol that remains elevated. We call those patients residual cholesterol risk. They were randomized into the IMPROVE-IT trial and into the Fourier and SPIRE trials, demonstrating PCSK9 inhibition was successful in such patients by reducing risk by about 15%, data we just learned at the American College of Cardiology a few months ago. But the other half of the adult patient population started on high-intensity statin therapy does not suffer from persistently high levels of LDL cholesterol. They suffer from a residual inflammatory risk defined by a persistent elevation of CRP greater than 2 milligrams per liter. But up until today, we have not had a therapy proving the concept that lowering inflammation in these patients would lower vascular risk. So the fundamental question being asked in the vascular biology and translational community for almost 30 years now has been, can inflammation reduction in the absence of lipid lowering reduce cardiovascular event rates? And I purposely show you here a patient with rheumatoid arthritis because of the commonality these two diseases share with atherosclerosis, but also because the kind of medications being used in that field is what we're now talking about in vascular biology. To understand the data I'm about to present, I must introduce a concept that may be new to many of you that has to do with something called the NLRP3 inflammasome. This inflammasome is a very important function in innate immunity that activates interleukin-1 beta. Interleukin-1 beta, in turn, has a number of direct effects on vascular function, but also activates interleukin-6. Interleukin-6, in turn, goes to the liver, puts out a number of acute phase reactants, very important for the clotting system, including plasminogen activator inhibitor type 1 and fibrinogen. And of course, the liver also puts out the biomarker of this process, C-reactive protein. For a variety of reasons, it's been felt that the interleukin-1 to interleukin-6 pathway was crucial to atherogenesis and clot formation, and the drug we used in this trial, canakinumab, is a human monoclonal antibody that targets interleukin-1 beta. The drug is a high-affinity human monoclonal anti-human IL-1 beta antibody. It's currently indicated for use in some very rare pediatric overexpression syndromes where children born on a genetic basis with too much IL-1 beta are treated. The drug binds IL-1 beta, functionally neutralizing its bioactivity, and it has a very interesting and long functional half-life such that we could design a clinical trial giving subcutaneous injections only every 4 months or 3 to 4 months rather than every 1 to 2 weeks. And in 2012, working with the sponsor, we published initial data demonstrating that the biomarkers of inflammation, in this case fibrinogen, interleukin-6, and CRP, were markedly reduced across a wide dose range of canakinumab with no significant effect on lipid levels. We therefore thought this would be a perfect scalpel to test fundamentally and for the first time the inflammatory hypothesis of atherothrombosis. So the Cantos trial was initiated in April of 2011 with the first randomized patient and just closed in June of 2017. We randomized 10,061 participants in 39 countries. All patients in the Cantos trial had suffered a prior myocardial infarction. The vast majority were on high-intensity statin therapy, the vast majority on ACE, ARB, beta blockers, and aspirin. The entry criterion said, in addition to all current standards of care, we only want to target this anti-inflammatory therapy to individuals with that residual pro-inflammatory response. So all individuals had a high sensitivity CRP level greater than 2 milligrams per liter at the time of study initiation. The trial design was complex. It included 3 different doses of canakinumab, a low dose of 50 milligrams subcutaneously once every 3 months, a medium dose of 150 milligrams once every 3 months, a higher dose of 300 milligrams once every 3 months, and placebo injections also every 3 months. The primary cardiovascular endpoint, hard MACE, non-fatal MI, non-fatal stroke, cardiovascular death. The key secondary cardiovascular endpoint inclusive of the addition with unstable angina requiring urgent revascularization. And today I will also review with you the cancer and infection data. Right up front, I want to thank Dr. Brendan Everett, who chaired our cardiovascular adjudication committee, as well as our death adjudication committee, as well as Dr. Howard Burris. We established an oncology endpoint adjudication committee at the very beginning of this trial. This was a group of oncologists looking at the cancer events, as well as Vance Fowler and Ajit Lemay, who were the adjudicators and chairs of the infection adjudication committee. And I also want to give a very special thanks to our Data Safety Monitoring Board, chaired by Professor Rory Collins. Cantos screened 17,482 patients worldwide. We had over 1,000 investigators committed to the idea that there might be a new way to treat atherosclerotic disease. We randomized 10,061 patients. The primary reasons for exclusion were CRP level that was below 2 or potential contraindications to the drug in terms of having risk factors for tuberculosis. As shown at the bottom of this slide, the discontinuation rate on canakinumab was exactly the same as it was on placebo. And I want to give a tremendous thanks to the structural part of this trial. We had single-digit losses to follow up at the end of this trial. I show you here the baseline clinical characteristics of the trial group. Median age was 61. Roughly 25 to 30% were women, about a quarter were current smokers, and 40% had diabetes. The vast majority appropriately were on very aggressive lipid-lowering therapy, renin-angiotensin inhibitors, and almost 80% had had prior revascularization already. I'd like to draw your attention to the baseline LDL cholesterol levels, which were 82 milligrams per deciliter, or roughly 2 millimoles per liter. That's a full 10 milligrams per deciliter lower than the LDL cholesterol levels were in the Fourier trial of PCSK9 inhibition, but of course we're not going to lower LDL cholesterol in this trial. But at the bottom of the slide is the crucial difference. This clinical trial required CRP levels to be above 2. The median was 4.1 to 4.2 milligrams per liter. That is defining a very pro-inflammatory group of patients. Again, for contrast, in the PCSK9 trials, both Fourier and Spire had CRP levels of just around 1 milligram per liter. This is the first results slide. If you look at the graphs at the bottom half, you see absolutely no change whatsoever in LDL cholesterol, HDL cholesterol, and a very minor 3 to 4% increase in triglycerides. In marked contrast, in the top of the slide, you see over time a marked and dramatic reduction in C-reactive protein, which as compared to placebo for the 50 milligram dose was approximately a 20% differential, and in the 150 and 300 milligram doses, approximately a 39 to 40% reduction compared to placebo. Please note that we did not see a large difference between the 150 and 300 milligram dose. In data not shown here but in the publications, we also measured interleukin-6 and again have almost identical differences between the 50 milligram dose and equivalent reductions in IL-6 for the higher two doses. One of the most important findings that come out of the trial is that the background placebo event rate for patients who are post-myocardial infarction on every form of therapy we currently have and on aggressive lipid lowering nonetheless have a very high primary event rate, running roughly 4.5% per year for the primary endpoint and 5.1% per year for the secondary endpoint. This is an important subgroup of patients at very high risk. I show you here the fundamental findings of the trial. For the 50 milligram dose, you see the hazard ratio is non-significantly reduced, 0.93, a 7% reduction for the primary endpoint, and approximately 10% reduction for the secondary endpoint, again, not statistically significant. But for both the 150 milligram and the 300 milligram groups, in which the reduction in CRP and IL-6 was almost identical and very substantial, both groups had, again, almost identical 15% reductions in the primary endpoint and 17% reductions in the secondary endpoint. Please be aware that it is the 150 milligram subgroup that, based on a very rigid and very technical statistical analysis adjusted for multiplicity across doses, was statistically significant at all thresholds for both the primary and the secondary endpoint. I show you here the Kaplan-Meier survival curves for the two doses of the drug that gave the identical doses for IL-6 and CRP reduction. As shown, the hazard ratio is 0.85, the p-value is 0.007. But again, I wish to bring to your attention, this is a 39% reduction in CRP, approximately the same reduction in IL-6, and no change in LDL cholesterol. This is almost identical data for the endpoint inclusive of unstable angina requiring urgent revascularization, now a 17% reduction in risk, a p-value of 0.006. If I can draw your attention to the area inside the red box, these are the hazard ratios for each of the components of the primary endpoint, of the secondary endpoint, and for additional vascular endpoints. A critical issue in this study is that all components had hazard ratios less than 1.0. Cardiovascular death was 0.9 to 0.94. All-cause mortality 0.92 to 0.94. These were not statistically significant, but again, they were in the right direction. I'd like to draw your attention to any coronary revascularization. All doses of the drug, including the 50 milligram dose of the drug, lowered the need for ever having a bypass surgery or an angioplasty by approximately 30%, and this audience is obviously aware of the economic implications that such a therapy might have. This slide shows you the subgroup data in the trial. I can go over it rather quickly because there is no subgroup in the trial based on gender, age, diabetes, smoking history, body mass index, or lipid levels that had a greater or lesser benefit. All patients in this trial simply benefited overall for both the MACE endpoint on the left and the MACE plus endpoint on the right. I would point out that effects were equally good among those whose native already treated LDL cholesterol was below 80 as those above 80. However, this slide deserves extra attention, and I think it's probably the most important slide I'll show you from a cardiovascular perspective. It's a pre-specified analysis asking the question, did the patient respond potently to this novel anti-inflammatory therapy or not? And so the data shown here are three lines. The placebo group in dark black, and then two on-treatment groups based on the level of CRP achieved at 3 months. The lower line, where the hazard ratio is 0.73 and the p-value is 0.0001, suggests a rather large 27% reduction in the risk of major vascular events if the patient responded to the drug with an on-treatment CRP level greater than the median value. By contrast, in the middle line, those patients who received the study drug but had a CRP reduction that was less than the median value at 3 months had a hazard ratio of 0.95 and a non-significant p-value. This suggests to me, from an inflammation biologist perspective and from a clinician's perspective, that we have a very simple way of knowing which patients might well benefit from this drug in the same way that we can measure on-treatment LDL cholesterol, we can measure on-treatment CRP, and define a patient population where we can maximize the benefits and minimize the risks. Like any new novel therapy, we have to be very careful about the potential for adverse effects, and this was a major issue in the clinical trial at the very beginning, particularly with our regulatory colleagues. Canakinumab is a novel agent that is known to induce a modest leukopenia. We saw that in the trial, although the magnitude of the leukopenia was relatively modest. On the other hand, the trial did show an increase in fatal infection. The events were relatively infrequent, but the p-value is statistically significant when one combines all doses and compares it to placebo. So just like patients with rheumatoid arthritis, where our rheumatology colleagues routinely prescribe anti-inflammatory, immunomodulatory type drugs, we have to be vigilant if this therapy becomes useful to us to make sure that we bring patients in early for infection and early antibiotics. I would like to ask you, however, to scan the rest of the p-values on this slide. I would point out that we have no liver toxicity and no kidney issues, but all the remaining p-values are statistically significant benefits of being on canakinumab, which is to say we had a reduction in incident rheumatoid arthritis, a reduction in incident osteoarthritis, a reduction in incident gout. All of those follow from the basic pathophysiology of the role played by interleukin-1 and interleukin-6 in the genesis of these disorders. But I also want to bring to your attention the line for fatal malignancy. A statistically significant reduction in fatal cancer events was observed in this trial. I recognize this is a cardiovascular meeting, so I need to give a little background here about why we were looking at cancer events in the first place. Our oncology colleagues have for many years been thinking about the roles played by immunity, inflammation, and cancer. Inflammation in the tumor microenvironment impacts upon the progression, initiation, and invasiveness, as well as metastases of certain kinds of tumors that are considered pro-inflammatory. The most important among those is probably non-small cell lung cancer. All of us as cardiologists have an intuitive feel for this. If we smoke a pack of cigarettes, or our patients inhale asbestos or silicosis, they are chronically inflaming the same NLRP3 inflammasome that we were talking about earlier, but now it's happening in the pulmonary bed. And it has been hypothesized that such individuals are at increased risk for lung cancer. And while all of you are aware that hs-CRP is a risk marker for future heart attack and stroke, you may not be aware that it's a potent risk marker for lung cancer. I want you to be aware that the hypothesis that inhibiting IL-1 might have some benefit in human cancer has been with us for several years. And I want to focus on the bottom of these three to work from Charles D'Inarello, who in 1984 cloned the interleukin-1 beta molecule itself. And he asked the question, why not treat human cancer with IL-1 blockade? To explain our cancer data clearly, I have to take you through 4 important points. First, the atherosclerosis patients enrolled in Cantos were at unusually high risk for certain inflammatory tumors, particularly lung cancer. The reason for that is they had older age. By selecting for atherosclerosis, were more likely to be current or past smokers, and because we had elevated CRP, a biomarker for lung cancer. Now please remember, the randomized double-blind placebo-controlled design of Cantos ensures that prevalent undiagnosed cancers at trial entry are equally distributed in the 4 study groups, as are the cancer risk factors that we know about and don't know about. And again, we had a cancer adjudication committee established at the very beginning of the trial. So I show you here the data for all-cause cancer mortality observed during the 5-year follow-up of the Cantos trial. The line at the top is placebo, and then sequentially coming down 50 milligrams, 150 milligrams, or 300 milligrams. A very powerful dose-response effect such that there is a 51% reduction in death from any cancer, at the 300 milligram dose with a p-value of 0.0009. Consistent with the biology of inflammation in the lungs, the great majority of that benefit appeared to be due to incident lung cancer. Again, you see at the top the placebo, then 50 milligram, 150, then 300, such that in the 300 milligram group there's a 67% reduction in incident lung cancer, here with a p-value of 0.00008. And finally, for the endpoint of fatal lung cancer, you see a similar pattern, in this case a 77% reduction in fatal lung cancer, again, highly statistically significant. So I'd like to draw several conclusions, if I can, about this Cantos trial. First, remember that Cantos was designed to directly test the inflammatory hypothesis of atherothrombosis. As shown in these data, inhibition of interleukin-1 beta with subcutaneous canakinumab given once every 3 months among patients with a prior myocardial infarction substantially lowered the inflammatory biomarkers high sensitivity CRP and interleukin-6 while having no beneficial impact whatsoever on atherogenic lipids. Concordantly, while the 50 milligram dose of canakinumab did not have cardiovascular efficacy compared to placebo during an average follow-up of 3.7 years, hazard reductions of 15% for the primary endpoint and 17% for the secondary endpoint were observed in both the 150 and 300 milligram groups, with the 150 milligram group meeting all statistical thresholds in the multiplicity adjusted analysis plan. In further analyses, pre-specified, the relative hazard reduction of 27% was observed among those with the lowest levels of on-treatment CRP at 3 months. This suggests that at least with canakinumab, lower is better not only for LDL cholesterol, but perhaps also for inflammation reduction. And as a clinician, this is a guidepost for me about who we might want to use a novel therapy in. Number 5, given mild neutropenia and an increase in risk of fatal infection, patients being considered for such a treatment will clearly require increased monitoring for early signs and symptoms of infection in a manner very similar to what our rheumatology colleagues currently do for the treatment of rheumatoid arthritis. Number 6, the placebo event rates in Cantos were very high, approaching 20 to 25% at 5 years, affirming that statin-treated patients with residual inflammatory risk, as assessed by an elevated CRP, have future event rates as high, if not higher, than statin-treated patients with residual cholesterol risk. These two groups of patients are different. They have a different biology for what causes their recurrent vascular events, and I think it's incumbent upon us to consider that perhaps we have different kinds of therapies to offer them at this time. Inflammation is also a determinant of the invasiveness, progression, and metastasis for certain cancers. In exploratory analyses within Cantos, those allocated to canakinumab had large dose-dependent reductions in deaths due to cancer, reductions in incident lung cancer, and reductions in fatal lung cancer, such that those in the canakinumab 300 milligram group had a 50% reduction in cancer fatality. Replication of these data is clearly required. In conclusion, these randomized placebo-controlled trial data demonstrate that targeting the IL-1 beta to IL-6 pathway of innate immunity with canakinumab reduces cardiovascular event rates and potentially reduces rates of incident lung cancer and lung cancer mortality. These data provide proof that inflammation inhibition in the absence of lipid lowering can improve atherothrombotic outcomes and potentially alter the progression of some fatal cancers. The Executive Committee and the Steering Committee, in addition to thanking the over 1,000 physicians worldwide who are open-minded enough to pursue this biology with us, also wants to thank the sponsor, Novartis, for having foresight and the willingness to work with us in pursuit of an entirely novel method of atheroprotection and cancer prevention. The atherosclerosis paper is available at this time at the New England Journal of Medicine, and the oncology paper is available at the Lancet. But finally, I want to thank the 1,000 investigators worldwide, the 1,000 coordinators worldwide, and the vast number of logistic individuals involved in making this trial possible. I have the honor of being in front of you today, but I simply represent a small part of an enormous group of very dedicated people who brought this science to us. So thank you for your attention today.